Our next speaker is Dr. Nada Al-Ashkar. Nada is coming from Johns Hopkins. She's a national expert in FSGS, and she has given several talks at a national and international level about recurrent FSGS. She will tell us about her expertise, and we're looking forward for your talk.
Thank you. First page. Good morning, everyone. Thank you so much, Tariq, and the organizers for inviting me to participate in this amazing symposium. I was looking forward for 10 years. I heard about St. Louis from Dan. He loves it. And the tour today was amazing. So as Tariq said, I'm going to talk about recurrent FSGS in 12 minutes. So that's what I'm going to keep. I promised him last night. Nothing to disclose. Those are the objectives. So basically, we're going to touch base on the pathophysiology of recurrent FSGS, how we diagnose it, the pathological changes, prevention and treatment, and the outcome. So one slide on the primary FSGS. To understand the recurrence, you need to really know what the primary disease that we worry about that will recur after transplant. So FSGS is very common glomerular disease that leads to end-stage kidney disease, about 35% of nephrotic glomerular diseases. And on light microscopy, you see 5 variants, as you know. However, the first site of primary disease is the podocyte injury. So when patients come to general nephrology seeking help, they're already too late. They already have the light microscopic changes of FSGS, but the first site is the podocyte injury. And the primary, or what we used to call it idiopathic FSGS, is the one we don't really know what causing it. So after you exclude genetic, infection, everything, and then you are left with that disease, the one progresses most of the time rapidly in the native kidneys, and we think is due to circulating factors, or called permeability factors. And here are some of the permeability factors that have been investigated, and we don't know if it's one factor or too many factors or a few of them that led to the primary disease. And those factors we think are the cause of recurrence. So going to the post-transplant, of course, the one, the focus of my talk is the recurrence, which is the primary disease that comes back in the kidney transplant. However, if you see somebody with FSGS and you know that primary disease was not FSGS, you have to look into other causes and, look for infection, medication. And later in the transplant life, if you do kidney biopsy, you will see the FSGS, changes, and this is the secondary process. But the one we really worry about is the recurrence disease that happens very quickly after transplant. And those are some of the factors that you really worry about. And when you evaluate a patient, you say, it's like, okay, you have all those risk factors, and I'm really probably concerned that you're going to have the recurrence. So hence, you need to keep close eye on those patients. So those rapid progression, young age, low albumin, previous failure due to recurrence in the previous transplant. However, we know that histological changes in the native kidneys do not predict the recurrence. So if you have somebody who's collapsing, progress rapidly, probably the rapid progression, not the collapsing, is the one that cause of recurrence. So we looked at those risk factors in our previous study. It was prospective data in 66 patients, and we found that not one factor is enough to predict. So those are some of the data that published in the literature, like white race, rapid progression. So if you have one of those factors, it may not predict. But when we looked at 3 factors out of those 5 factors, the recurrence, the prediction value is increased significantly, about 70%. So if you see patients with some of those predictive values, you counsel them about, I'm really concerned you may have high risk of recurrence. And in the Tango studies, they found 4 predictive factors, such as old age, white race, body mass index, the high range, and the native nephrectomy. So as I mentioned, we think it's one of the permeability factors or more that really lead to the recurrence. And those are some of the permeability factors that are studied in the transplant population. as I indicated before, SUPAR, TNF-alpha, CLC1, which is one of the members of IL-6, angiotensin receptors antibodies, and some immunoglobulin. So I'm going to just briefly touch base on some of those. So you heard about SUPAR many years ago. We were really excited. We thought probably that's the cause. However, probably some groups still have higher SUPAR levels and have recurrence. The mechanism is SUPAR binds to beta-3 integrin, results in podocyte injury. There is extensive work in that era. In transplant patients, this is a study that came more than 10 years ago, showing that by Dr. Reiser and his group, patients who have higher SUPAR level associate with high recurrence, and then patients who have recurrence after transplant have higher SUPAR level than the patients who did not have recurrence. And another investigators found that SUPAR level was much higher in the urine comparing to in patients with recurrence versus no recurrence. And they did not see the serum SUPAR was higher. We participated in this study with Dr. Sarwal, and we found that 7 immunoglobulin really were higher in patients who have recurrence, and in particular anti-CD40. And there are some more publications on anti-CD40 antibodies that by itself was much higher in patients with recurrence versus no recurrence. We published some data on angiotensin receptors antibodies. First case, a patient had de novo FSGS. And then we looked at our data with everybody, about 100 patients who have angiotensin receptors antibodies, and we found 50% almost they have de novo FSGS or recurrence, or they have proteinuria. So it is possible in subgroup that patients with anti-angiotensin antibodies, they participate in recurrence. And this another data from Indiana showing exactly the same, that patients who have recurrence have higher angiotensin receptors antibodies than patients who did not have angiotensin receptors antibodies. And of course, probably you saw some case reports, especially in pediatric, about TNF-alpha, that patients who did not respond to treatment with plasmapheresis, they give them doses of TNF-alpha. And this work from McGill, which we participate also in, that's showing anti-TNF-alpha blockade decreased significantly the podocyte injury and podocyte culture in patients who have recurrence. So hence, it's probably some group have they have TNF-alpha that cause of recurrence FSGS. This one case report, which I just presented it here because it's really interesting, and I know a few groups they're working on anti-nephrin antibodies. It just was elevated in a patient who have recurrence FSGS. So it's probably one of the causes. So in spite of all what I told you about permeability factors, we still rely on protein creatinine ratio to diagnose the FSGS. And it's really important to monitor those patients who you really think they have high recurrence rate or predicting recurrence, and monitor them very closely after transplant, and we rely on the proteinuria, protein creatinine ratio. And most of the time, if you're concerned, you don't know if the proteinuria is real, or because the patient still has hematuria, we do 24 hours urine collection. And of course, if you're still concerned, patients still making a lot of urine from native kidneys, we do kidney biopsy and we ask for electron microscopy. And the first sign, of course, when you do kidney biopsy, you may get called like, the biopsy is normal, why are you doing the biopsy? It's like, I really want the EM, because it's really, that's what you want to know. If there's significant podocyte effacement, that means that patients have recurrence. And you don't want to wait until you see like microscopic changes. You need to start treatment right away. And of course, if that patient has proteinuria and that happened late, you may need to rule out other causes, as I mentioned. So as I said, in pathology, you want to see the electron microscopy, and you see significant podocyte effacement. You see in this, am I pointing? Yeah, here, the podocyte effacement. This is the light microscopic changes is very late sign. And of course, if the injury persisted, you may see the podocytes start to be detached, and you will see them in the urine. However, you need to know that the type of the light microscopic changes may not predict the recurrence. So you may have tip lesions, and then the recurrence will be collapsing. So it's not all the time the same pathological changes. So how to prevent and how to treat. Of course, as I mentioned, you see somebody and he says like, I'm really 70% sure that you're going to have the recurrence, and you have those patients. And what you're going to do, you say, okay, I'm gonna prevent it. I'm going to do something, and I'm going to show you some of the data. We were really excited 10 years ago when this data came from Miami, showing giving a dose of rituximab the night or before the transplant decreased significantly the recurrence rate in those patients who are have high recurrence tendency. So we did that in our prospective study, and we used rituximab in 36 patients. And unfortunately, we really did not see that recurrence rate decrease at all. I mean, there was no difference between the patients who have the rituximab dose or not. And other groups show exactly the same. And this data came a few years ago showing exactly similar to our data. Giving rituximab dose did not really decrease the recurrence rate. And of course, we were focusing on those patients who are very high recurrence tendency. How about plasmapheresis? Of course, there are some published data, and especially in pediatric, doing plasmapheresis before transplant, if you have the chance, or after transplant if somebody get deceased donor. So we did it both. We did it in somebody who has live donor, few plasmapheresis before and after transplant, or somebody had deceased donor, we say, okay, let's be proactive and do plasmapheresis 5 to 10 sessions. And in spite of that, really, we did not see decrease in the recurrence. And this meta-analysis looking all published data, many case reports or small series, and similar findings that plasmapheresis, or with us, plasmapheresis and rituximab really did not decrease the recurrence rate. However, treatment is still rely on plasmapheresis and, of course, rituximab. So in most part, and most of you guys, of course, and us, we do plasmapheresis. We do initially about 9-10 sessions, and most of the time the patients respond to that, and then we give a dose of rituximab, or sometimes more than one doses. And if somebody did not respond, we extend the plasmapheresis treatment. So that treatment became probably the treatment of choice. So similarly, in retrospective data, we found the same, giving extra dose or giving rituximab after plasmapheresis in our prospective data should decrease the relapse after that. And then in retrospective, we found that rituximab dose decreased significantly proteinuria. So now that treatment of choice is really plasmapheresis and rituximab, and of course ACE and ARB. Similarly, in this study that came a couple years ago, and then in this French data showing exactly the same for patients who did not respond well to plasmapheresis, giving dose of rituximab really decreased proteinuria. So, and this data meta-analysis also looking at all the data published and found more than 70% of the patients who in those series, almost 378 patients, the major treatment is plasmapheresis, and the response was almost in 70%. So what do you do for those 30%? Most of us have some of those patients in our centers that they don't respond to plasmapheresis and rituximab. We did some data with Dr. Brennan and Dr. Alhamid, that showing ACTH was really helpful on those patients who were resistant to plasmapheresis and rituximab. So we gave them ACTH, and about 50% responded to treatment. So finally, the outcome. In our data, we found that patients, the vast majority responded to the treatment with the plasmapheresis, rituximab, ACE and ARB, or ACTH. And then we have 8 allograft loss out of 38 who have recurrence. In this registry showing that patients' survival decreased significantly in patients with FSGS, about 30% decrease. And of course, that's compatible with the patients who did not respond to treatment. Similarly, in the TANGO, about 40% of patients who have recurrence, they have allograft failure early post-transplant in the first few years. So recurrence is very high in post-transplant. Monitoring still rely on urine protein creatinine ratio. The work is still ongoing to find the permeability factor that we can rely on for diagnosis and for prognosis, and of course monitoring. Early recurrence early findings on biopsy is podocyte effacement, so you really want to rely on this before light microscopic changes. Treatment with plasmapheresis, rituximab, of course ACE and ARB always, and some other treatment, as I mentioned, ACTH, TNF, alpha blockade, and cannot be nephrology talk without SGLT2 receptors. And thank you very much for your attention. 12 minutes.
We have time for a couple of questions.
Alistair, that was a great talk, Nana.
Thank you.
In our candidate evaluation clinic at SLU, we've started a genetic protocol for a couple of reasons to inform the evaluation of related living donors as well as for disease recurrence. Just wondering if you see any role for genetics or other biometrics in evaluating.
Yeah, I mean, really great questions. It's I get similar questions from our group, like Hopkins last week, and we haven't yet. I really think this is a great idea. At least if you have genetic, as we we know, it's like rarely that will have recurrence. It's like, yeah, I'm comfortable, you're good, but exactly. But we haven't implementing this. At some point, really should be part of the evaluation.
Great. Thank you so much.
Thank you.
Sorry, one question.
Yeah.
Have you used the sparse sentence for FSGS?
No, not yet. Yeah, thanks.